Very good. Hello, everyone. Welcome to our final week of the Hormone Boot Camp through Vibrant Wellness. We are very honored to have Dr. Brandon Brock with us today to talk about the menopausal brain. So Dr. Brandon Brock is a highly accomplished clinician and educator. He serves as the staff clinician at Carpathia Wellness and clinical educator for Erconia Medical. He holds a doctorate of nursing science, PhD from Texas Women's University, and a doctorate of nursing practice, DNP from Duke University, a doctorate from chiropractic from Parker University, and he is also the postgraduate global clinical research scholar from Harvard Medical School. Beyond his professional achievements, Dr. Brock has 4 exceptional children. His wife, Tara Brock, is an outstanding health coach who collaborates with him in patient care and is his life partner, bringing immense joy. Together, they love traveling, staying active, spending time with friends worldwide. They passionately support health, faith, wellness, and living a fulfilled lifestyle. Their shared mission to bring hope to those who are sick and have lost their way. We are so honored to have Dr. Brock with us today, and I'm going to go ahead and have him take it away because we have a lot to cover. So sit back and enjoy. Thank you so much, Dr. Brock.
Thank you, Dr. Bruno. Can you hear me good? Everything's good?
Yep, all good.
Perfect. All right. I always like to ask that so I don't just talk to myself. Well, first of all, it's an honor to be able to be here and talk about such a topic. And this is one that just about everybody will run across either personally or clinically. And when we're talking about brain, there's a lot of things that factor into that in regards to health and your cognition and being mentally fit. And then, of course, when you talk about hormones, there's a whole lot of things that can happen there, obviously, as well. So the things I want to say today is, first of all, there's enough information in this to do a whole weekend course. So I'm going to go a little bit rapid. So please just try to bear with me on that. And I'm going to try to take you through a whole test so that you at least understand the basic premise of the markers and what they mean to brain. And the other thing I'll say is there's like a lot of layers to hormones. There's hormones and menstrual cycles. There's hormones and dysmenorrhea, amenorrhea, pain, other conditions. There's all these layers. I'm just putting the brain layer on it. I may talk about some other stuff, but what's really good, the fact that this is a boot camp and it's a series, is that you can take all these different lectures and kind of start to layer them. And it does take some time and it does take some work. But when you start getting a little bit better at hormones, and not just hormones, but their metabolites, you can really start to understand why cognition changes with hormone fluctuations or mood changes or all these things. And that's why it's so really interesting to be able to talk about this and share. So I just kind of wanted to lay that out. I put a lot of stuff on the slides. I don't normally put this much stuff on the slides as far as verbiage, but so when you go back and look at it, you have some stuff to read. And when you get the notes, you have some things to read as well with some references. So anyway, that's kind of what we're looking at there. Again, this is great. Let's just sit back, enjoy the hour or however much time I got. I'm going to try to get through all of this where it's not just ridiculous, but we can actually do it. So this is just my information here. I have some disclaimers on the bottom. No financial gain really out of this from anything that I'm going to be presenting. I won't be presenting on anything that I particularly formulate or do. All right, so here we go. Menopause, that change and there's always hormonal fluctuations that are going on. I want everybody to understand there's multiple things that are feeding into this. It's whether it's ovarian or testicular or cholesterol or adrenals or the influence from thyroid. I want you to start from the very beginning and understand that there's a lot of stuff feeding into these things. And that's going to be interesting to understand, like, why does brain health and hormones fluctuate when there's stress or adrenal maladaptation? What about with ovarian changes? Or what about with brain output changes through stimulating or releasing hormones? So a lot of layers on this, but it's the one thing that I want to connect is that where there's a neurotransmitter, there is a hormone that is going to influence that neurotransmitter. So we're kind of a slave to what our hormones tell us is going on and our resultant neurotransmitter reactivity. And then there's also cytokines. And this is the immunological system that is communicating as well. So cytokines, whether they be pro-inflammatory or non-pro-inflammatory, hormones, and then neurotransmitters, and then synaptogenesis, they're all going on together to make these neural networks in different parts of the brain function. So I may say progesterone is associated with GABA. It's associated with a lot of other stuff, but to make it simplistic, or estrogen is associated with serotonin, testosterone is associated with dopamine, and then whether it's pro-inflammatory or anti-inflammatory. And then I may come in there and say adrenals are associated with this other hormone, which is associated with this neurotransmitter. So there's little lines and little stories and little sequences that go through this. And I just want to try to pull it together into stories. Like, what's the story of estrogen and how it breaks down? What's the story of progesterone and how it breaks down? Where is it going to the brain? What's it doing to that neurotransmitter? What is that part of the brain doing that makes somebody agitated, have insomnia, have mood changes, have depression? And I think whenever we start to put this together, a lot of light bulbs will turn on. You'll say, that's why that patient is going through this. And then you'll start to see the importance of looking at hormones. There's some people that work with brain and all they do is hormone work. They don't do a lot of the other stuff. So if you do thyroid work and hormone work, you're that much better. If you do functional neurology and hormone and thyroid, you'll be that much better. So it's just a cool layer. You can spend your whole life learning about this stuff, and that's what's so exciting about it. So, and I hope you can see my cursor here, but we're going to talk about the neurotransmitters and what happens during hormonal shifts. And we know that menopause is obviously a big one, right? And then how the neurotransmitters correlate, maybe throughout the cycle, and how you can see them sort of change, and how you can watch your patient's behavior, mood, demeanor, everything can change dramatically and very quickly sometimes. And then, just looking, and this is what I like to look at, is how do hormones shift, change neurotransmitters, and it changes plasticity of the brain. So you don't have those neurotransmitters that makes you have plasticity or connectivity in the brain. And so you start to get a lack of plasticity and the brain does not connect as well. So you start to lose function. And you can even get excitotoxicity and cell death from some of these fluctuations. So the big question is, how do we measure them? How do we monitor them? How do we look at it? And don't get frustrated. It does take time, but when you practice this for a little bit, I promise you'll get good enough to where you'll be able to answer a ton of questions that a lot of people can't. So again, you can see a lot of words over here, but when I say estrogen, it impacts serotonin. One of the things that estrogen does is it goes up to your brain and it goes to receptors where serotonin is at, and estrogen comes up and it says, hey, look, here's what I want you to do. I want serotonin receptor. I want you to work better. So estrogen will sensitize serotonin receptors to work appropriately. It's just one of those mechanisms where a hormone has an impact in a lot of other areas, but it comes up to that one spot and it says, okay, react to the serotonin that we have. And so just to kind of put it in perspective, a lot of people that they're going through menopause, they have a shutdown of the ovarian, capacity or function, and they're not making as much estrogen. A lot of times what happens is they end up getting put on an SSRI. And as a result, they're getting put on a medication because of depression. And their estrogen goes down, serotonin goes down. So now the logical answer is to put them on an antidepressant. We see this all of the time. Okay. So it's just one of those things that is just there. If you don't have it, of course you can get depression and irritability and mood swings. All right. It has an impact on dopamine. So for instance, estrogen supports dopamine synthesis and serotonin receptor sensitivity. And so look at serotonin as the thing that makes everything a little bit more vibrant in your life, and look at dopamine as something that gives you the sense of hope. And so a lot of times when dopamine's going down, motivation will be impacted, mood can be impacted, and they just lose pleasure and they get fatigue. Whereas when it's looking at serotonin, again, it's sometimes difficult to measure neurotransmitters accurately. I mean, if you measure serotonin, that's cool, but 90% of it is utilized in your gastrointestinal system. So you don't know exactly what you're measuring per se. But when somebody has serotonin issues, you're looking at that irritability, that depression. It can be dominant. It can be non-dominant. I'll go through that in a little bit. And then dopamine is that, anhedonia, where it's like a lack of pleasure and fatigue. So both of them can cause depression, but they look a little bit different. And the reason why I talk to you about that and how to kind of look at it and assess it is there's not the best tools to measure it. There is some, but just talking to your patient and kind of getting into their mind a little bit and seeing how they're visualizing things. If they're not doing well and they're having mood, is it mood and anxiety and emotional well-being, or is it a lack of pleasure, fatigability? And then a big one is concentration, okay, especially with dopamine. So dopamine goes up to the front of our brain and it activates it so our frontal lobes come on so that we can pay attention. And this is like with ADD and ADHD, some of the stuff that's going on. They don't have the good dopamine surging and signaling to the brain. And most of ADD medications are pushing dopamine to go to the brain to activate it so that you can pay attention, okay? So a lot of people, when they go through hormonal shifts, one of the things that occurs is they feel like they have attention deficit issues. Another thing is estrogen is going to impact GABA and glutamate. GABA slows the brain down. Glutamate excites it. We have to have glutamate. It turns your brain on. We have to have GABA because it comes right around and says, where you were turned on, let me turn you off. And there's all kinds of things that can go wrong. If you make glutamate, you should make a fairly equal amount of GABA to come around and support that. And sometimes it becomes skewed. You get more glutamate and less responsive GABA, so the brain stays active and you get things like anxiety and insomnia, and you can't turn it off. So estrogen does that, and we find that all of these hormones really play on the same systems, but some a little bit more on others. Like, for instance, progesterone has a lot to do with GABA. Most of us know that when somebody takes progesterone at certain times, it helps them sleep, it helps with anxiety, helps with brain injury as well, and I'll talk to you about that as we go. But GABA receptors are really responsive to progesterone. And one of the reasons why we do the testing the way we do, and we don't just look at progesterone and we look at the metabolites, is because the metabolites of progesterone all have an impact on different things, okay? Like I'll go through allopregnanolone and some of the other things, big impact on keeping those GABA receptors appropriate to where they're responding to your GABA and they're not working, inappropriately. And if they're working inappropriately, that brain doesn't have the ability to shut down and cool off. And sometimes glutamate can go really high, and then it can push a cell up and it's firing at a very high rate. If you've had brain injury and you have that glutamate at a high rate and you don't have GABA to cool it down, it can go into an excitotoxic mode and you can actually start to destroy neurons. This is a problem with head injury because things get very close to threshold. And, whenever we have anything that's going on, whether it be brain inflammation, brain injury, and it's very close to threshold and you have more glutamate, you don't have GABA or magnesium and other things controlling it, you can exceed its metabolic threshold. And when you lose a neuron, they don't undergo mitosis, so they're gone. So this is very neuroprotective. And a lot of you have probably used progesterone for sleep, for insomnia, for anxiety. A lot of times we use it for head injury too. And if you know their underlying hormonal terrain, you can determine when you need to use progesterone strategically. It's really cool. Measuring hormones with head injury is actually something that's not something that a lot of people do. But when you do it, you can say, man, this person's really prone to having this problem. Let's go ahead and support them hormonally, and it's much safer. Testosterone. So when I say testosterone, you say dopamine. So when I say estrogen, you say serotonin. When I say progesterone, you say GABA. When I say testosterone, you say dopamine. Mainly. Not conclusively, but mainly. So I'm trying to give you some easy correlations there. Testosterone is impacted or impacts dopamine, and that really helps with mood. So when you have somebody that comes in, let's say female, going through a certain point in their life where their estrogen's dropping, and you're always trying to figure out, do I or do I not give testosterone with this? And you're measuring the levels. When you look at the metabolites and everything, it gives you more information than just looking at a serum testosterone level or serum estrogen levels. And I'll kind of go through, I do like to do those, but looking at the little nuances of taking progesterone or estrogen and then looking at its metabolite and how they break apart and the body uses them, and then how it breaks it down into excretable metabolites and what that does if it doesn't work, that has a whole different set of consequences. So we know that libido and depression happen with testosterone's impact on dopamine. So when you're looking at this and somebody is deficient in estrogen, you're like, wow, they have mood swings, they have a little bit of irritability, they're fatigued, they're just not doing well, and they have some depression. And then if they have low dopamine at the same time, now they have low libido, decreased energy, depression, and they may be, feeling some like loss of pleasure and hope in their life. Sometimes a lot of these things can all kind of come together, but so going through this, when we have depletion, again, it's a little bit redundant here, but I just want to make sure that I kind of keep giving you the same linear thought process. When serotonin is depleted, we get depression, irritability, low mood, and anxiety. If you throw a little bit of dopamine reduction on that, now it turns into I'm not motivated, I'm even more fatigued, and I can't focus on top of it. So there's a few words there that's in one but not the other. focusing, dopamine, not as much with serotonin, okay? And then again, going into GABA, it just further gives the, agitation, the irritability, but this is where people become really restless, and, sleep becomes a big, big problem. Sleep is also a problem with serotonin. There's so much, interchangeability here. So, and then going down to the, again, glutamate, irritability, sleep disturbance. These are the people that also, if they get any MSG or excitotoxins, they do terrible. Food dyes, artificial sweeteners, MSG and stuff like that on food, it can knock them out for a couple of days sometimes when they're not doing well, because it can exceed the threshold of the brain and it kind of starts to shut down, and it takes a little while for it to kind of get back on par per se. So just setting some rules there. So we have perimenopausal depression, and these are some of the things that, again, we see whenever we have hormone fluctuations, and we're talking about perimenopause and menopause. And look, this stuff starts in your 30s, give or take, and it can go all the way through your 40s. And then right around the end of the 40s, it changes even more into the 50s. And you can watch people change along that course. But with perimenopause depression and the estrogen and the serotonin, the depressive levels, again, progesterone and its metabolites, I'll go through those, people can start getting panic attacks. Because GABA, when it's not there, it doesn't cap the amygdala, which is your fear center. So when progesterone goes down, GABA is not controlled, the amygdala goes up, you can start having panic and fear that's not capped by GABA. And if you don't have good serotonin and dopamine acting the frontal lobe to control that amygdala, it gets even worse. So a lot of people can go from full-blown anxiety to insomnia to panic attacks and then constant worry. And I know many of you have seen patients go through this where they come in and they're not doing so good, then they're doing worse, and then they are having to take all kinds of medications. Sometimes they come into our office and they're on 3 or 4 medications, and that's a whole different deal. And then again, the bipolar like mood swings is something that is there. And I'm going to talk a little bit also about cortisol, serotonin, melatonin, and your cortisol rhythm and your melatonin rhythm as well, and how important that is for brain. Now, I just thought this was kind of a cool little slide here, and I try to put good references on here and a hyperlink to some of these. Well, this just shows, I talked about glutamate, excitation, GABA, inhibition, dopamine, dealing with frontal lobe and pleasure reward, and serotonin, which is stabilizing mood, and of course, giving you, activation, plasticity, and things like that. I'm not going to go through each of these little dots, but all of this stuff, if you look at the trend, it's all running from really your mesencephalon and your pons, or your brain stem, your midbrain, and below. So it goes mesencephalon, pons, and medulla. These centers that deal with these neurotransmitters are there. So hormones come into the central nervous system, impact or have an impact on the production of these neurotransmitters. Then these neurotransmitters go up to different neurons, and it creates an interaction between, synapses. And so the hormone has an impact on the cells that are making the neurotransmitter, and on the ability to have synaptic connectivity and sensitivity between the neurons and other areas. So it's doing all kinds of stuff. It's making the neurotransmitter and then allowing it to work. And that's one of the ways that hormones go in there, and it says, okay, estrogen is here, let's have pleasure. Dopamine's here, let's have hope. Let's have a libido, and move on with life and enjoy all those different parts of it. And when that kind of goes away, I just kind of say you're losing your mojo. So on the right side of the screen, I kind of divided up at the top where we have our progesterone, and then in the middle we have our androgens, and then below that we have our estrogens. And I'm going to break it up into those categories, okay? And I like to use this stuff from the test so that you can learn to start to look at it a little bit and correlate a part of the test with what we're looking at, with symptoms. And so it kind of starts to assimilate into some sort of, when you look at this test, it doesn't just look like a bunch of scary lines and everything. You can actually say, okay, when something's going on there and they're having these symptoms neurologically, then there's a correlation. And I'll talk a little bit about what to do with it, but it's just a whole nother layer where an hour is difficult. So adrenal, hormone, medication, various health conditions, all of these things are going to play into this and give downstream effects, okay? Pregnenolone is what I call the doorway. So we know that we have cholesterol, and it's going to turn into pregnenolone. And pregnenolone is an interesting thing because it can go in a bunch of different directions. It can go into a progesterone pathway. It can go down into an androgen pathway. You can go through aromatase and then go down into an estrogenic pathway. And a lot of people always wonder, when do I use pregnenolone? When do I not? Sometimes whenever you give somebody pregnenolone, you can't necessarily choose which pathway it's going to go down. It'll depend on the metabolic efficiency. So I call this front end loading the system. You can give just the hormones, which is back end. You're just going to say, okay, it's not there, I'm just going to give it. Or you can give the precursors like pregnenolone with DHEA or pregnenolone with progesterone, and you can give a sort of a bias where you load that pathway in one direction or the other. There's not a ton of literature on pregnenolone's efficiency. And one of the reasons why is because it's really watered down. It loads the whole system and it goes into a bunch of different directions. But sometimes I'll stack it with different things. So if I really want to push progesterone, I can do progesterone and pregnenolone, or I can do progesterone and DHEA rather than just testosterone and so forth. So I like to talk about pregnenolone a little bit. A lot of people are like, when do I use it? And remember, using pregnenolone all the time or DHEA all the time can sometimes shift these things to where now you have an inappropriate ratio going in one direction or the other. And it's not always good to give these things all the time. So we do kind of try to measure them a little bit. All right. So here's one of the things. So it's like, if you look at just progesterone, every one of these things are metabolites. And I really don't expect anybody to sit here and memorize every single one of these metabolites. If you want to, knock yourself out, okay? But I'm going to go through a few of them that we know that are important and that we do have literature on and that are clinically relevant. And I'll talk about those and break them down. Otherwise, if we go through all this, it becomes so freaking overwhelming that I just think you lose people. People don't want to do the testing, and so they never learn how great it is and what they can do for patients. These are your progestins, or your progestin, the components of the progesterone that's actually going to be your metabolites and then your excreted metabolites. And that's looking at this one part of the test. So if I go back to right here, we're just looking at this top section right here. Okay. So as we go down a little bit further, here this is, and this right here shows just how complex it can be. But we're going to look at this one part and then some of the progestogens that are actually going to be metabolites of normal progesterone. So we're not just looking at normal serum progesterone anymore. We're looking at what it's going to break down into, its metabolites, and each of these are going to have different impacts on the system and look a little bit different. So you can take some of the neurological stuff we talk about it, correlate it to the test, and then say, that's why I'm seeing that. I can do some stuff to help that one section and reduce the symptomatology neurologically. And these are the things that, in particular, the Vibrant test, these are some of the markers that it's going to be looking at. Now, the reason why I put the list over here is because this list doesn't match with what you see right here in regards to what's being measured. You see alpha and beta pregnadiol, but there's some stuff that's in between that and some other metabolites that aren't on that just overall topographical map of the hormones. But I do want to put these over here because I'll talk about these and you'll be like, wait a minute, that's not on the initial map that he showed us, but I want you to be mindful of these things that are being measured and how they fit in to this schematic on the top. So I'm going to give you, and again, we have to get into biochemistry a little bit, because if we don't, it doesn't make any sense. I don't want you just to memorize this equals this. Kind of what is the flow? So you have progesterone in the system. And then the progesterone is going to convert into various metabolites. And this is where a lot of people, they don't understand the metabolites. Some people that do a lot of just medication-based hormone replacement therapy, they don't sometimes look at the metabolites. Some people that are in functional medicine love the metabolites, but they don't look at the medication component of it. Trying to pull a little bit of it together here. So progesterone through 5-alpha dihydroprogesterone, and then there's also a 5-beta dihydroprogesterone. These are going to turn into alpha pregnadiol and beta pregnadiol. Those two things, if you look at that, they're on here. So we have an enzyme, and then we have the metabolite. And this is a really nice little schematic I pulled out of a paper. And I already told you that progesterone equals GABA. Remember that. And so as we break it down and we go from progesterone all the way to the 5-alpha dihydroprogesterone, and we eventually get to these end metabolites, and allopregnanolone is one of those as well, they're all going to cause gene transcription for plasticity. That's why we like to give it after head injuries. And then it also activates GABA receptors, so people will calm down, not have the anxiety, and not become excitotoxic and then start to fail metabolically. If you've had a head injury, or if you have an inflamed brain because of a million other reasons, sometimes controlling this excitotoxicity can reduce stress on the brain and reduce the resultant GABA problem and GABA receptor problem that people have. So for instance, some people that are taking benzodiazepines, things like alprazolam or diazepam, Valium, Xanax, things like that, they get off and they have terrible discontinuation. Well, those GABA receptors, they repopulate. But if you have a progesterone problem on top of that, it's even more difficult to recover from that. And sometimes they're taking progesterone in lieu of a benzodiazepine because they still have a problem. Sometimes people that have a progesterone issue, they end up getting on benzodiazepines to take care of this because they're having so much anxiety and panic. I would really rather see somebody get their hormones looked at, their progesterone corrected, control GABA receptors that way, and then not get put on a benzodiazepine. And it's almost impossible to come off because they don't want to have seizures and other discontinuation issues. So sometimes we can really help somebody's life out by just helping out their hormones, and they don't get stuck on a psychiatric medication. Same thing with SSRIs and estrogen. Now I say benzodiazepines and progesterone. So those are two things that go together sometimes. So if somebody's coming off of it, you can help their progesterone. To keep them from getting off of it, or to get on it in the first place, you can look at progesterone and say, man, they just need a little progesterone. They're going to calm down. They don't have to get on a benzodiazepine. It's life-changing whenever you can catch somebody at that point, okay? So what do these guys mean as we break them down a little bit further? I talked about that enzyme that eventually gives us to alpha or beta pregnadiol, okay? So the alpha, if you look at this, the alpha reductase that gets us to that, alpha pregnadiol level, it can alter progesterone. Beta does the same thing. And then we have a couple of other ones here. We have a 3-alpha hydroxysteroid dehydrogenase. So there's a 3-alpha and a 20-alpha. There's a 5-alpha reductase and a 5-beta reductase. These are all things that are giving us metabolites: alpha pregnadiol, beta pregnadiol, allopregnanolone, and then this guy right here has a really neat little thing. So let me kind of go through these and break them down. They're all going to equal things that are going to alter GABA. It's also going to have an effect on your androgens, and we'll get to that in a minute. But when we get down to this 3-alpha, this is a big one that modulates GABA receptors. And because the allopregnanolone, if we end up having a problem with this metabolite, this is one of the reasons why people that have progesterone imbalance and they have an alteration in this particular metabolite, it has a huge impact on GABA receptors, okay? Again, can affect mood and cognitive function and plasticity. When we get down to this 20-alpha, it, again, really has some very similar things. It has a downstream effect, again, on GABA. It's a redundant thing, progesterone and GABA. That's why I kind of told you that there's a theme throughout each one of these hormones. So I'm going to talk, again, more about the reductase and the alpha pregnadiol, okay? Whenever there's a problem with this particular metabolite on the lab, it's going to be, you can automatically think GABA, you can automatically think anxiety, the amygdala, which is where all your fear is stored. You have to have an amygdala that has your hippocampus and amygdala are right next to each other. And your amygdala and hippocampus work together, and your hippocampus says, hey, I store memories, short-term memories. This is what goes away with Alzheimer's disease. But your hippocampus says, here's what I just remembered. And it tells your amygdala, it says, you know what? You should be really cautious of what just happened because it could hurt you. And it tells the amygdala that, and your amygdala says, okay, cool. Let's create a fear response so that we have a memory, stay away from that thing. If the tiger is going to eat you, you remember the tiger. And whenever you see it, then you have a response to it to get away. It's a fear response. The amygdala will store those memories. And so if you don't have a frontal lobe that comes down to reason with that, and the frontal lobe goes away, your amygdala can heat up doesn't really heat up, but it becomes very dominant, and you get fear responses. Some of these fear responses have been there since you were a child from adverse childhood events, and they start to become more pronounced. And now people respond more from events that happened way back because they don't have that frontal coverage over that or cap over it. Well, when progesterone goes away and these metabolites are abnormal, or progesterone is not being utilized, metabolized, and excreted appropriately, the amygdala is now like, hey, everybody, I'm here. The frontal lobe goes, okay, well, I'm not so here. And your worst nightmares become very, very, very pronounced. And it can become, you can get major anxiety from this. Think about how many patients you know that are going through this, okay? That's the relationship between the amygdala and the hippocampus. So remember, where there's GABA, GABA works with serotonin. So progesterone's more GABA, a little bit serotonin, but then you have estrogen, which is more serotonin and less GABA. So when you have progesterone and serotonin issues, it becomes a double whammy on this. And this is one of the reasons why I don't like to just give a lot of one and nothing of the other, or support. I like to support both of them. So a lot of people come in and they're on a lot of estrogen, but they're on no progesterone. And so it gets skewed, and you start to see a mood disruption just from the fact that they're not in ratio with each other. So the anxiety and stress can become overwhelming with these metabolites. So when you see that on the lab, just start thinking, oh, Dr. Brock said GABA, and Dr. Brock said something about the amygdala and the frontal lobe shutting down and having insomnia and anxiety and all of these things that people come in and they just seem super stressed out and they're not doing well. And this mood instability becomes irritability. All right. Now look, with this marker, these are the women that get, and I just say women because that's what we're mainly talking about here, premenstrual. This is your dysphoria or dysphoric syndromes. And this is also big, listen, postpartum depression, okay? Such a big deal. So when you look at dysphoric disorders, you have to look at this marker. It's the brain is not working well. There's a lot of fear and a lot of frontal disconnection. And then when you look at postpartum depression, you have to say, well, there's a lot of hormones that can be involved, but I know that the metabolites, especially the alpha pregnenolone, could be a problem. Let's just take a look at this test. We know it's run. I showed you that portion on there. It's just really two good markers, and it gives you a little index, and you can look at it and say it's good or it's not good. Sometimes it makes a big difference. So the beta, not the alpha, but the beta, this again, mood disruptions. This one, I told you that with the alpha, we get the dysphoric disorders, but when we start looking at the beta, now we start looking at premenstrual syndromes. So these are the people that get perimenopausal mood disorders. It's not quite defined in dysphoria, but it definitely is, PMS type of symptomatology. So people that are having bad, PMS, premenstrual type syndromes, you can look at this marker as well. And I think it's really cool to be able to look at those two things and say, this is related to one thing, this is related to the other. I know they interchange. They're both with GABA. They're both with the amygdala. They're both with fear. They're both with anxiety. And you can just run right through that. The reason why the frontal lobe disconnects is because progesterone has a lot to do with GABA, but it also pushes dopamine to go up to the frontal lobe to activate it so that it will do this. Your frontal lobe, again, looks at the amygdala and it says, I know you're worried about this, but just take it easy. Let's make some sense out of it. Or I know you're scared about this, but let's just put order in our day and, don't procrastinate. We'll get through it. You can put this on the back burner, not this. So your frontal lobe is that executive brain and that reasoning. When you lose dopamine and serotonin, that executive function goes away and you're just you're pure limbic is what a lot of people say. You become very limbic, okay? So we have, again, just kind of going through, we have the alpha and beta pregnadiol. Another metabolite is allopregnanolone, okay? Or allopregnanolone. Very, 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 very GABA. And this has a lot to do with controlling glutamate. So the other ones were very GABAergic modulating, but this one also controls, things like glutamate. It makes it to where it doesn't become so excessive. So whenever you have a problem with this, you can get the anxiety. All these things can happen. This is where post-traumatic stress disorder lives. So I already told you, again, I hate to keep going back, but the alpha, dysphoria, beta, PMS, allopregnanolone, PTSD. It's not quite that simple, but I'm trying to give you some things that are just really correlative, okay? So when you're taking progesterone and progesterone's good, maybe there's not as much postpartum maybe there's not as much dysphoria. Maybe there's not as much PMS. Maybe there's more GABA control. They don't need to take a benzodiazepine. They can sleep a little bit better. They have more wellness. They just feel more controlled and calm, and they're not as prone to having PTSD, either from things that happen at that time or maybe even PTSD that resurfaces from that amygdala that's uncapped. And now all of a sudden they're having vivid childhood memories and they're reacting emotionally to it, whereas they didn't before. If you knew how many people got put on medications because this is screwed up, it is mind-bending. Okay? So that's why this is cool. This is not the cure for all PTSD, dysphoria, and PMS, but it is something that needs to be investigated. And if you learn it and you know how to look at it and deal with it and at least address it and know it's there, you might be able to make a change and reroute somebody's entire life. Because when you get these negative emotions, they start to build plasticity themselves. And now fear gets plastic and turns into worry. And now that turns into compulsive thought. And now you have no choice but to give them a psychiatric medication to control it sometimes. Terrible way to go. So that's why I see it. And I see everything from a functional neurological perspective anyway, because that's where I started. Man, when you start talking about this, anytime somebody has an inflamed brain, if you look right here, their NMDA receptors, the magnesium goes away, it gets uncapped, they get excitotoxic, and then the cells become unstable, and boom, apoptosis occurs. So dealing with excitotoxic brain damage, progesterone is protective. It's protective against head injury. And that's why a lot of people with head injuries get PTS, because they get excitotoxicity, and then this turns on. Magnesium is a big one. Magnesium glycinate, anything but the magnesium like oxalate or citrate, that stuff is really good for bowel movements, but all of the threonates, all the glycinates, and the protective magnesiums, they cap NMDA receptors. So the progesterone-induced glutamate excitotoxicity that you get is not as pronounced. Big thing. So progesterone and magnesium goes a long way sometimes with head injuries. All right. So I told you about the 20 alpha. Okay. And again, this dysphoria that we get, or this dysphoric type of thing where, mood disturbances, and some people feel disassociated with their body and things like that. And they're having a really hard time with this. And then of course, perimenopausal stuff and cognitive decline happens with this. People will describe it as, I have brain fog. I can't think clearly. I can't remember things the way I used to. Well, they're being honest. They don't know how to explain it, but they're doing their best to do it. So anyway, just going through these, we have a ratio here. And the reason why I think this, because I told you that sometimes you need some estrogen, sometimes you need some progesterone. Well, we have a ratio for that. We have a beta pregnadiol or an E2. I'll go through estrogens in a minute. And it's amazing how fast time flies when you're having fun, right? But I'll go through the estrogen to progesterone ratios so that you can start thinking to yourself, is this really low progesterone? Is this low estrogen causing this? Because they look very similar. They can both cause mood problems, irritability problems. But you can start to look at the ratio and say to yourself, I think this is more related to the progesterone system or more related to the estrogen system. And I need to support one system a little bit more than the other. People that are using medications to help these people, they can ratio the dosage. Or people that are dealing with the metabolites and nutritional support to get these things moving, they can look at supporting one more than the other. It's actually a beautiful thing when you look at this ratio and what they mean to each other. So if the beta pregnadiol to E2 ratio is too high, it indicates more progesterone relative to estrogen. So maybe you need to support your estrogen system, okay? If it's vice versa and it's too low, it indicates higher estrogen relative to the progesterone. This can lead to anxiety and irritability. The reason why I leave this here is because, you can go back and read this over and over and over and say, okay, look, I know what pregnadiol is. I know what E2 is. I know this ratio. If it's too high, more progesterone. If it's too low, more estrogen. And you can look at it and say, is it estrogen dominance or is it progesterone deficiency? You want to try to get these two both working, but both working equally. And so, we realize right out of the gate that they look so similar that we have to have the ability to differentiate. Do I need to support both of them or one more than the other when it comes to brain health? Because depression can just be depression. Not everybody can describe it and break it down so clearly as we have here in the description part of it. But progesterone is neuroprotective. Estrogen gives you synaptic connectivity and neurogenesis. Without estrogen, and if estrogen is not appropriate, you will go into cognitive decline very rapidly. The average age of onset for dementia in my female population is 52. Wow. I wonder what the correlation between there is. And that's a scary number, 52 at least. So cognitive decline versus irrationality and all kinds of dysphoria and things like that. So again, progesterone, GABA, estrogen, serotonin, and dopamine. Testosterone, we'll get into that in a second. And again, I know I'm whizzing through this. There's no other way to do it in an hour. But we can break this down and so slowly. It's just freaking it's fantastic stuff. So, all right. So during menopause, right? We get this ratio gets skewed, and now one goes up, one goes down. It's not balanced out. Maybe the ovaries are failing. Maybe we're having some adrenal problems on top of it, and it's causing all kinds of things as well. But you're going to start getting a little bit of wobbliness in the mood, a little bit of irritability, and then they start to get some brain fog and some focusing issues. And you can clearly say there's probably some issues going on here with hormones. So we know that with postmenopause, progesterone and estrogen levels, they start to decrease. They don't always decrease at the same rate. It depends on what your genetic makeup is. And this is going to start to present as neurological and mood issues. And then that's when these ratios really come into play. So as somebody's starting to go into menopause, they're starting to not have as many periods. Their FSH is starting to climb up a little bit. That FSH climbs up. It turns on your thermostat. It causes vasoconstrictive, vasodilative capacities. You start having, hot flashes and stuff like that. I do look at that through serum. And then as we see those levels declining, we can look at this and break it down into even more detail and say, we know they're both going down, but estrogen is really suffering here, or progesterone is really suffering here. If your adrenal glands are not good, you don't have that adrenal support to push your own estrogens anymore. So they really plummet whenever you have stress and maladapted adrenal glands. Okay, so now I'm going to go into some of the androgens. So that's progesterone. I'm just giving you a basic glazed over overview of that. Hopefully you got a few things out of it: the dysphoria, the PTSD, the postpartum, the PMS, and things like that. I just think that alone is worth, just the time being spent on it. So you see over here, and again, you're up, there were these lines. I just did the beta and alpha, right? But there was some, the alpha, the 3, the 20, they were in there. Those are things, those are metabolites, and those are components of the the metabolism of progesterone. It's not shown on here, but they're part of the measurements. That's what I want you to recognize, okay? Now, when we start to go into the androgens, we have all of these things, all this DHEA, all the way through the androstenedione and diol, all the way down to testosterone, all the way to DHT. And what does DHA do in the middle of this? Okay, so DHEA, a lot of people are giving DHEA. I mean, think about it. Pregnenolone and DHEA pushes these pathways. It's like saying, okay, look, if it's not good, let's front end load it, rather than just go to the back end and say, let me give it to you. Sometimes when you get good at this, you say, I'm going to give you a little pregnenolone and then support progesterone and then give you some nutrition to help with the enzymatic components that deal with the metabolites. And you start learning how to really get good at that and chisel it, and it becomes fantastic. Sometimes you have to do more back end loading. Sometimes you have to do more front end loading. DHEA and pregnenolone, you may now be saying, okay, look, I really want to actually pull you into the androgen pathway a little bit and kind of push it in this direction. And so we know that the adrenal glands, so cholesterol pushes into all of it, and the adrenal glands push into DHEA. So you may have a bias between your progesterone and androgens and estrogens based upon what your adrenal glands are doing. So if they're weak, it's going to look totally different than somebody where if they're not weak. All right. So DHEA enhances the serotonin. It enhances the dopamine by pushing these pathways. There are liver enzymes that are involved in the hydroxylases that allows us to convert cholesterol to pregnadiol or pregnenolone and then DHEA as well. Okay. So look, if you have low levels, well, why would it give depression, fatigue, cognition, decline, and anxiety? Because you don't get the end result hormone that deals with the neurotransmitter. So when DHEA is low, it looks just like one of those hormones is low. So sometimes we can find that and say, aha, I can just give you some DHEA, support your adrenal glands. It's going to fire into your androgens. You're going to make more dopamine. Your frontal lobes will light up, and voila, you're going to do better. And they do. Okay. But when they're low, no wonder why we have things that are like depression and anxiety and hyperactivity and agitation and restlessness. And you start getting all kinds of, secondary other androgenic effects like, hirsutism and acne and stuff like that in regards to females, because testosterone is messed up. So it can cause some problems there. Mood fluctuations. It also has a big anti-inflammatory effect, and it's very, very big for neuroplasticity because hormones are responsible for synaptic connectivity, which creates plasticity. And again, plasticity is just one neuron firing to another. It becomes efficient, and now they're wired and connected together, and they're staying together, and the nervous system proliferates in regards to its connectivity and is more efficient. Okay, so we take a step down, and then we go to androstenedione. And again, adrenals, adrenals, adrenals. But now we also have gonadal components, males obviously firing from gonads, females firing mainly through their, adrenal system. But all that's firing in here to preload all these other downstream metabolites and things that you need, like testosterone and DHT. Again, low levels of this equal the same thing. You're not front end loading it. And so we see things like with PCOS a lot of times, and so when you start looking at PCOS, think insulin resistance. And when you think insulin resistance, think this. Insulin resistance has this terrible way of, in men, making your testosterone low, but your estrogen high. And in females, your estrogen low and your testosterone high. So I guess you would say it turns girls into guys and guys into girls as far as their hormonal makeup. And so you can get secondary sex characteristics related to that. And obviously that may not be a desirable thing for somebody. So we go a little bit further, and then now we have kind of some of the end metabolites. You can see all of these are measured down here. And in particular, androsterone, it deals with more GABA, and it's the androgenic component that helps you stay calm. So everybody thinks of testosterone as being, rage, but there's also a calming component to it as well. So if your testosterone system or your androgens are going up, but one portion is not going up, some people are more prone for rage. When this one goes up, it sort of caps some of the rage. It's also a significant part of libido. All the androgens are part of libido, as well as estrogens as well. So just think, as we go up here, kind of a little bit more calm. As we go down here into testosterone and DHT, it can deal definitely with more rage. Acetylcholinone. So this is another one. So we had DHEA, we had the androsterone, and now we have the acetylcholinone. So this one right here is low levels in this. I mean, this directly starts, getting more into, are you going to get into testosterone, the usable parts that really go to tissue, the different areas and make things happen. But 5-beta reductase, the metabolite, and you can look up here in regards to being 5-alpha or 5-beta dominant. But a metabolite of testosterone is this one particular part, androstenedione, through the liver, 5-beta reductase. These are less potent in regards to androgens, but they do have a lot to do with mood, fatigue. A lot of people that, when these pathways are messed up and their testosterone is low, they will be very flat. They don't have as much mood, and they're just not, a lot of people get a little bit of depressed feeling because they just don't feel that activity. They can also get systemically inflamed whenever this is low as well. And they can get systemically inflamed. They don't control. These are some of the people that as adults, they can get adult onset, or they can have febrile seizures with a small fever. We saw this in COVID sometimes. As people would get COVID, they would get a spike as an adult. If they had neurotransmitters that were really messed up, they could start they're much more prone to seizures. If you put progesterone on top of that and they're excitotoxic, they could also start getting plasticity, where they would get enough glutamate release and excitotoxicity where they would have seizures. And that can become plastic and then turn into a little bit of a disorder there. So we're just working our way down this list. So we know cholesterol is loading it, adrenals are loading it, maybe gonads are loading it, and then we're breaking it down into all these different metabolites. As we go down, we start going into some of the, other components, but we have to realize that some of these are going to deal with, just be calm. Don't have inflammation. Let your testosterone do some of that great stuff for you. Because as we go further down and we see testosterone, it's now going to break into less androgenic and more androgenic components. Okay. This is where we start to have dopamine modulation from testosterone, which gives us motivation. So people are taking testosterone, they're calm, they're motivated, they get better bone structure, they have a better libido, and all that's, going on. It's great. Just remember, if you give too much testosterone too long, receptors will start to downregulate, and now the honeymoon is over and you actually get lower libido, guys and even gals, from taking too much testosterone. This is why I tell guys, if you start taking too much testosterone, that awesome libido that you get, it's going to go away. If you're bombarding those receptors, they'll downregulate. And it happens for dopamine too. So people will go on a cycle, they'll come off of it and they get major depression. Their motivation goes down. They don't have emotional resilience when you take away their testosterone, or if they've taken it too long, they start getting dull. All the beauty is now gone. Okay. So all of these things, whenever you don't have good, androsterone and acetylcholinone, these are the calm ones. If you don't have these up here, but your testosterone is a little bit more efficient, you'll get the irritability and you'll get the aggression, but you won't get the calmness. So when these are imbalanced, especially in females, sometimes they'll take testosterone. They do get really aggressive from just a small amount. Guys, it usually takes a little bit more, but once you reach a critical threshold, you can get, the classic roid rage. Now we start getting to things like DHT. And DHT is the most powerful component of androgens. If somebody's taking steroids and it goes straight to DHT, some of the oral ones turn into DHT, it can destroy your liver, causes terrible acne, your hair will fall out. I could never imagine a female taking this, but a lot of guys do because it creates massive strength very, very quickly. But this is also your erectile, component. Testosterone, DHT equals great erections. And so if you take things like prostate medication, or if you're taking stuff to preserve your hair, it's blocking your conversion from testosterone to DHT. And so it can have massive sexual side effects, and it can start, altering your mood. And whenever these are, and a lot of guys, again, whenever DHT goes up, it can create baldness. Mine's genetic, but it can also make your prostate enlarge. So they're taking these blockers that will make it to where you don't go from testosterone to DHT. Well, I mean, sometimes that's good if you want to keep your hair, but it can change mood. It can also change cardiovascular protection and brain protection and dopamine protection as well. And it definitely can have an impact on libido. So we go up here in the less androgenic. This is your 5-alpha androstenediol. And again, this is very GABAergic. So dopamine, testosterone creates that dopamine and that aggression and that motivation to get through life, but it also does it in a way to where you're calm and you can just be like confident. If it gets skewed, you just get the aggression and activation, but not the calmness. So it gets skewed and it just looks like irritability and mean. So when these things are imbalanced, you can kind of tell somebody that's on testosterone therapy, they may not be doing so well because they're not loading the lower androgens. They're loading the higher, more androgenic components, and their behavior gets skewed from utilizing it or pushing that pathway or giving back and loading. Aggressive behaviors. Again, just going to the 5 beta component, again, GABA, calm, stopping some of that. If it's really high, you can get aggressive behavior, but if it's low compared to the other more androgenic ones, then you can really have some, problems with focusing and stuff like that. Testosterone has a lot to do with focus because of its dopamine connection. So just kind of looking at this real quick. And again, I apologize for going so fast. I just want to be able to get through it and give you some things to just grab a hold of, okay? High androgens, again, aggression, irritability. How much of that is going to depend on how it skews. Okay, if you have a reduction in some that give you the calm component, and you have the other ones that are there that are very highly androgenic, you just get aggressive and mean. If they're all balanced out, you get motivation with balance, and you don't get that skewed aggression. If it's low, it always equals depression, fatigue, belly fat, low motivation. Dopamine's not there, frontal lobe disconnects, you become fearful, all of that. It looks very similar to progesterone. Okay, so estrogen. Wow. I'm going to talk about aromatization real quick, and I'm going to have to cut through this really quick. Aromatization is where now we're going from the androgens and now we're jumping into the estrogens, okay? If this is messed up, it can lead to significant plasticity problems. Your hippocampus in regards to memory can go down, because if you don't aromatize into estrogen and you're not making it, even if you're a guy, you don't have the wonderful estrogen to back up the testosterone. A lot of people are taking testosterone and they take aromatase inhibitors, so they have no estrogen. They become mean, disconnected. They don't have synaptic connectivity, and they can start to get not the serotonin that they need. They're getting the dopamine, but they don't get the serotonin they need from it at the same time. So you got to be able to connect the two so that you can have serotonin working with dopamine. You can have motivation connect with rationality and understanding things from an empathetic perspective. So as we do this, aromatase is allowing all of this stuff to connect to everything down here below it. And estrogen is extremely good at dealing with oxidative stress in the brain. It stops apoptosis in the brain. It deals with hemodynamics in the brain in regards to stroke and so forth. So here's all the metabolites. I know. We have 3 estrogens. So I'm going to run through these quick. We have E2, our main one, estradiol. Okay. And we know that it's huge. If you don't have any estradiol, bye-bye hippocampus, short-term memory loss, beginning of, serotonin goes down and acetylcholine goes down. So now we have short-term memory loss and mood disruption. We have E1. Now, E1 is highly related to adrenal glands, okay? So high estrone levels can be associated with estrogen dominance. So now we look at ratios between E1, E2, and E3. If those are skewed, you'll see different components that'll relate to estrogen dominance. And if you have estrogen dominance, now we get things like significant irritability, depression, weight gain, man. And this also is a hormone sensitizer for cancers. E3 is one that we see a lot that has a lot to do with placental function. I really want to say something here. It's important that you understand that all of these estrogens control your ability to have immune regulation so that when you're pregnant, your estrogens help regulate immunity so that you don't get autoimmunity during pregnancy. And that's important. A lot of people you may see this immune modulation component from E3. So when you get pregnant, your E3 goes up. It's placental. Now your immune system becomes regulated. Your Hashimoto's goes in remission. It's the greatest they've ever felt in their whole life until, of course, afterwards. But as E3 starts to rise, it's very, very calming to an overactive immune system. Again, just a nice little tidbit that you can take away. So we have several of these. All of these estrogens are dealing, again, with balance in a way to where you have good serotonin, you don't have depression or cognitive issues. And then we have this ratio. So I told you we have a progesterone to estrogen ratio that we did higher up here, but now we have ratios between all the estrogens. And you can see which one of these is irregular amongst the 3 of them. Are they all playing well together? Some people that do medications and stuff like that, they'll say, I need more E1 or E2. And so they'll start doing ratios like with biased and things like that. But, when you start looking at these E3, E1, or these E3 to E1 plus E2 ratios, when it's low, I want you to understand that's estrogen dominance. When it's high, now it indicates more potent estrogens, reduced cognitions, and poor mood. I just wanted to make sure that you understand that ratio. It's important to look at when we're looking at estrogen dominance. When we look at the other ratios that I talked about in regards to pregnadiol and stuff like that, or progesterone and estrogen up top, that has to do with estrogen being imbalanced with progesterone. And now that we're down here, we're looking at 2 estrogens compared to another estrogen and their independent ratio and what it will do. All right. So I'm just going to say this. We have hydroxylation and we have methylation. So we have hydroxy pathways and we have methyl pathways. All right. Now, it's really important to understand these. We have to be able to support metabolism through, the COMT pathways and through, methylation pathways. And I want to get to this one point. Well, let me go back. Sorry about that, folks. So we have all this breaking down into hydroxylation and then into methylation as well. One thing I'll say real quick. So people will have a catechol-methyltransferase gene abnormality or a methylation abnormality. Remember, it takes methylation to build these up. It takes hydroxylation to kind of get rid of them. And so just remember, when you have COMT gene abnormalities, if you drive methylation too high, there's a sensitivity to their methylation and you can create anxiety. So sometimes you have to use a hydroxylator versus a methylator. Obviously, if there's a methylation pathway with methoxy levels, then you would want to use methylation. I've got to the point where I use like methylfolate or methyl, cobalamin and hydroxyfolate or hydroxycobalamin together at different ratios. So I'll look at these. If the hydroxy pathways are no good or COMT is no good, I'll put some hydroxylation in there and not just methylation, because if you skew that and they have a progesterone problem on top of that, you can give them significant anxiety from overmethylation. So I give 3 things: methylation, hydroxylation, and adenylation. Adenylfolate or adenylated, it supports the mitochondria. Hydroxylation supports these pathways and methylation supports these pathways. And instead of trying to guess, I kind of give all of them at the same time, but sometimes at different levels. It's not just all methylation. If you have a bad COMT issue, but not much of a methylation issue, you can sometimes drive them into a period or a place that is not so good. Okay. That's just a big point that I wanted to kind of get across. And then again, your total estrogens, looking at that ratio is going to help you with your estrogen dominance and so forth. Okay. So just kind of jump into it. The hydroxylation process is looking at COMT. It's very, very, if these pathways, if hydroxylation is good and your liver's doing good, it's going to be very protective against harmful metabolites, things that can be, carcinogens and stuff like that. Methylation, again, it also involves the COMT SNP, but sometimes it again can get sensitized to methylation and it just doesn't work well at high dose. Sometimes you have to graduate it up. And again, all of these things are neutralizing your estrogen metabolites and byproducts. So what I did here is, and you guys can come back and review this, I just kind of gave a breakdown of hydroxylated versus methylated versus adenylated, and then gave you a summary in regards to that, okay? Just remember that if you have a lot of plastics and bisphenols, BPAs in your system, it's going to screw with estrogen metabolism, even at the level of the receptor site and your serotonin. That's one of the reasons why BPAs are big right now. Okay, I'm going to touch on cortisol for like 5 minutes. I just want to tell you something real quick. So your hypothalamus tells how much cortisol you need to release. So one thing real quick, I want to say, your adrenal glands become maladapted. It's not that you get adrenal burnout or anything like that. It becomes your cortisone stored to free cortisol becomes maladapted. You're not releasing that. Or the output to your adrenal glands is abnormal because your hypothalamic output is not saying make cortisol. And then your hippocampus and your suprachiasmatic nucleus and your paraventricular nucleus, your suprachiasmatic nucleus deals with light, like it's time to shut down the cortisol and let melatonin go up and go, you can go to bed. It takes the hypothalamus to say, let's go, and your hippocampus to say, let's go, get that cortisol awakening response up really high. And then your hippocampus keeps it modulated throughout the day. So you have the hypothalamus saying go, you have the chiasmatic nucleus saying stop, it's time to make melatonin, and the hippocampus is in the middle saying, okay, we need a little bit more here. There's some sunlight, the sun's starting to go down. And so your cortisol fluctuates throughout the day. All right. And so there's one buzzword here that I'm going to go through. And let's just get to this one point. So we have really the ability, you have to look at this and say, can I take cortisone and convert it into cortisol? If you can do that appropriately, then great, you got free cortisol. If not, you have a bunch of stored cortisol and cortisone and it's not released. So we have our brain saying, let's do this. And then we have different parts of our body saying, cortisone, let's just release some cortisol out of this so that it can actually be in the system, okay? Obviously, if there's too much cortisol, people get anxiety, they get hypervigilant, and they also have, a whole lot of other problems. If there is no cortisol, people feel very flat. It looks like a lot of the other hormones that can be screwed up, okay? So the one thing that I really want to kind of get to is this. This is your beta hydroxysteroid dehydrogenase. There's type 1 and type 2. So I'm just going to call it, just for ease, a dehydrogenase. We have type 1 and type 2. This is very important for you to understand before we get done with this, okay? So we have type 1 and type 2. It's going to take cortisone and turn it into free cortisol, or cortisol and take it back to cortisone, okay? So when we have high cortisone and you don't have free cortisol, now it's depressed. This is what looks like adrenal burnout. That's what I wanted to get to here. When we have low cortisone and we have higher cortisol, it turns into anxiety and stress and all that stuff. It looks like they have, overactive adrenal glands, okay? So when you look at this right here, the enzyme dehydrogenase type 2 converts cortisol to cortisone, while the type 1 goes from cortisone back into cortisol. Lots of things can dysregulate which one of those is active versus the other. So when you look at an adrenal gland, if the whole thing is low, maybe brain output is not good, or maybe they have 21 hydroxylase to the overall adrenal system. That turns into Addison's disease. If you have enough, but then it's fluctuating throughout the day, maybe inflammatory cytokines are screwing with your hippocampus and your hypothalamus and your other neurotransmitters. If you have great cortisone and no free cortisol, and that looks like what we would call adrenal burnout, it's maladapted to where your dehydrogenase type 2 and type 1 is imbalanced, and it's either staying all stored or it's all being released into free. And stress can throw those off, which is why the adrenal glands will maladapt. So it's not that it just decided not to work anymore. It's there's an imbalance between stored and free, or the brain is saying don't have an amplified response, or the hippocampus and the suprachiasmatic nucleus are not controlling your normal cortisol rhythms. So man, going through all that is the big thing. And I just want to kind of get to, and I really gave you a good breakdown on some of the stuff that will start to skew the 1 versus 2 in regards to the enzymes that will go from cortisone to cortisol. Okay. And look, if your cortisol is up and your cortisone is down, it's going to give you chronic anxiety and insomnia. Imagine if you have that with, altered progesterone, it gets even worse. And they're highly correlated to each other. All right. So we know that when you have really a problem here and we get elevated free cortisol, this can lead to obesity. It causes metabolic syndrome that messes with your, aromatization. It can also deal with estrogen to, testosterone ratios and all of your estrogen ratios as well. Cortisol related obesity is around the belly and belly button. If it turns into insulin resistance, it now goes around the side and the love handles. If it gets worse, it goes up the middle of your back and over your shoulders. That's the fat distribution. All these things go together. I mean, I wish we could just talk about insulin resistance and then how it messes with all these levels. But again, I'm just trying to give you an overview of each system and what it's doing in regards to brain right now and how they kind of play with each other a little bit. So just remember, anytime any of these are low, it's going to cause depression. So when somebody comes in and says, I've got depression, you don't know if it's estrogen, if it's progesterone, or if it's cortisol, unless you look and say, is cortisone related to converting to cortisol? Is progesterone balanced out with estrogen? Is estrogen metabolizing? And are all the estrogen working together? And so that way you can kind of start to understand, is it testosterone, dopamine, estrogen, serotonin, progesterone, GABA, cortisol, and how it fires into all of these systems. Okay, so I just want to kind of jump down to this one thing here real quick. And again, guys, this is so much information. One thing real quick, melatonin is really neuroprotective. I want to throw this in there. So if you have high cortisol, it'll, in the evening and it spikes before bed, one of the things it'll do is it'll start to lower your melatonin. Melatonin is very neuroprotective at night. Melatonin is also a major Th1 stimulator. That's why a lot of people were giving it to people with COVID, because it was a Th1 stimulator and it was doing things like it was antimicrobial. That's great unless you have a Th1 dominant, immune system. I just wanted to throw that out there. Some of you guys like that kind of stuff. Melatonin is a major Th1 stimulator, but it has to be appropriate in the night. If you have hypoglycemia in the middle of the night, it screws this up. If you have insulin resistance, it screws it up. If you have maladapted adrenal glands and your cortisol is spiking at night, it'll make it to where your adrenal glands, like that suprachiasmatic nucleus. This is some people that have real dark rooms and stuff like that, because they have to block out all that light to reduce that sensitivity so they can have the appropriate cortisol to melatonin rhythm. I love the fact that, Vibrant is doing this evening melatonin and cortisol rhythm along with the daily cortisol rhythm as well. So anyway, I don't know who to give credit to for this. I have over the years have gotten this, all this put together. I give this to my patients sometimes and they can just circle the things that they have. And then I can go through this and say, wow, it looks like estrogen is at play or progesterone is at play, and which one looks more related than the other. You can take this and subjectively overlap it with the labs and then start saying this is mainly progesterone, or it's mainly estrogen, or it's mainly adrenals, or it's mainly cortisol not going to, or cortisone is not going to cortisol, or, cortisol is just totally elevated and cortisone is really low. It can help you start to understand what you need to pay attention to in the lab, When you do your physical exam and you do your history, what their symptoms are, is it anxiety, or is it just low mood, or is it low hope, or is it low wellness, or is it low motivation? And when you start to kind of hear all this very, very abrupt information that I gave you in an hour, but you start to learn more about it and you start to look at their mood, you start to look at their cognitive function, you look at something like this where you can say, okay, well, here's all the symptoms they got. And then you look at these labs and their metabolites and you break it down, you can say, aha, I got it. Progesterone is mainly at play here. Aha, I got it. Estrogen is dominant here, or estrogen is just deficient here, or one estrogen is more inclined than the other one. How is estrogen playing with progesterone? Or is your cortisol screwing with the whole system? Or is your adrenal glands, as it comes into DHEA, is it messing with all of it? Or is cortisol itself messing with all of it? There's a lot of players here. The one thing I just want to bring attention to is you now know the players. If you can learn how to break those players in the game down and say, I know that this one's more involved than this one, you don't just become the adrenal person, or just the person that gives progesterone to everybody, or the person that just says, here, take your estrogen. And yes, it is safe to give testosterone sometimes, and it's absolutely necessary. And when you give it, sometimes you have to give supplementation to help push it into one portion rather than another portion, so that you don't get more androgenic component than you wanted. Whew. Okay, so there's a lot of information right there, guys. I know it was very quick. Please don't go away and say, man, that's too much. I didn't get anything out of it. You can go back, read it again. That's why I put a lot into the notes, because I knew there was going to be a lot of information in this. Just break it down section by section: progesterone, GABA, estrogen, serotonin, testosterone, dopamine, cortisol, dealing with all of it and how the brain deals with those rhythms. Yes, I'm going to probably do a class on this later on where it breaks it down better, but at least it's fun to get a fundamental understanding.
Wow, that was so much amazing information. Thank you. Thank you. And thank you for everyone hanging in with us. I know that we were all just like riveted watching. So it is overtime. We understand you're in the middle of your clinic day, but if you can stay for some quick Q&A, please do so. And a reminder, the PDF of the slides and the recording will be sent out so you guys can go through all of the text on the slides, since it was a lot of information. So I'm going to pull up a couple questions that we have here, and we will go through. So I'm going to try and head up to the top. Sorry. Okay. So if someone has low hormones across the board and slightly elevated liver enzymes, does that paint some sort of a particular picture in your mind?
Yes, it does. That's a good point. We saw all of those, CYP, those phase 1, phase 2 detoxification enzymes and stuff like that. So I will often give liver support. So I'll measure, do liver support, measure again. Before I give like hormone replacement therapy or something like that, I'll try to make the liver a healthier place, and then see if we're starting to kickstart the front end loading, and see if it makes the back end to where you don't have to give a drug or so many medications. And then also, after you support the liver, then you can do some other nutritional stuff to help with the metabolism along the way, so that maybe you get even more that way. And it's a really good question, because it's a big, big concept. A lot of people just say, screw the liver, screw helping with the metabolism. Let's just go straight to the end and give everything there. But now they still have a sick liver, bad detoxification, and it's going to turn into poor health somewhere down the road. This is a great question. And I think that whoever is asking this question is probably thinking in a very linear fashion that makes a lot of sense.
Awesome. So I think this relates to this other question of, if giving the hormones, people are having worse side effects. This probably goes back to more of the processing enzymatic flow, but any other thoughts that you might have here?
Yeah, just remember, and again, I didn't get to break it down as much as I wanted to. And if I gave anybody neuroexcitotoxicity from the lecture today, I apologize. Take your progesterone, you'll be okay. No, but listen, if we already have like estrogen dominance per se, because of the way all of the metabolic cascade is to making it and then getting rid of it, if we start to feed a pathway that's already backed up and then creates a greater problem in regards to its metabolites, you can really give somebody a bad day if you give them estrogen and you don't know how they're going to break it down. Or if you have just like a lot of estrogen and you don't give any progesterone, now you get an inappropriate relationship between those two. So that's why it's like I'm very hesitant sometimes to give like estrogen unopposed and not support the progesterone system, especially if it's already messed up. Point being is that if you give one of these things and it's already not being broken down the right way and you're driving pathological pathways, you can end up getting metabolites that cause secondary symptoms just by giving it. They don't break it down and metabolize it because they're not, methylating it or hydroxylating it appropriately, and you get abnormal accumulation of, metabolites that are just not so good. So it is not unusual at all. And then you also have to look at what kind of hormone you're giving them. Sometimes they're put in certain bases, like if it's compounded, where they just can't tolerate it because they're sensitive to it. So yeah, that's another great question. If you see that, go back, look at the test, and see where you're maybe messing up a little bit or where the problem is. And sometimes you can just tweak it a little bit and make some changes, and all of a sudden it gets 100% better.
Wonderful. I know this presentation was primarily about menopause and the changes there, but thoughts on similar hormone changes for female teens and a lot of these teen girls who are being put on antidepressants.
Yeah, well, so just look at it. I mean, insulin resistance is one of the greatest things that we're dealing with right now in America. Okay, so I'm just going to give you an example of this insulin resistance. If there's insulin resistance, metabolic syndrome, changes in leptins, all of that stuff, and you're getting pro-inflammatory cytokines, it's going to skew the way they're going to metabolize, break down, and utilize their hormones. We see a lot of people getting estrogen dominance and all kinds of things. Their menstrual cycles get disrupted, the timing of ovulation, luteal defects, all different types of, just defects. If they're not breaking these things down, and we're seeing people get more stress as their kids, they're getting exposed to more diseases, infections, and conditions and environmental toxins, which also affect these hormones. It will dysregulate them. I know I stayed more towards the older population talking about menopause. It's not so much like ovarian failure. It's just hormonal metabolism through the whole little network of things we talked about. When that is not appropriate, you're going to see somebody that gets insulin resistance. It's going to mess with estrogen. It's going to alter progesterone. They're going to have changes in serotonin, and they're going to be sad, or they're going to have problems with adjusting. They're going to have problems with social, being social, and they end up, nobody looks at this stuff. So what's the answer? Take the pill. And that is, there's so much of that going on right now. You can go anywhere and find that going on with, it's all over the place.
Wow. So much to unpack there. I'm going to do one more question and then let everyone get back to their clinic days about precursor to pregnenolone as far as LDL and HDL. Do they affect the same way?
Ooh. Let's bring the cardiac test up.
All right. So we're going to have a week 6, 7, and 8 now.
Man, I really apologize. There's so much wonderful. I love talking about this stuff so much, and there's so much in there. I just want people to understand like how much there, when you really get, it does not take long to get good at it. But back to this question, overall cholesterol is the molecule that's going to turn into pregnenolone. There's a bunch of different, esterification and stuff like that goes through that. But LDL, some of the things, whenever you break cholesterol down into its other, factions, they don't have quite the same effect. They have more of an effect on the heart. Like, for instance, if LDL is oxidized, or if there's more small, dense LDL, things like that, that's very, very atherogenic and causes significant oxidative stress and tissue disruption. So when you break LDL and HDL down, I'm not going to give it as much importance as I would just the cholesterol molecule. I don't know, without getting into like an entire different lecture, I would just say this: look at your total cholesterol levels. It's not a good idea to just take your cholesterol levels down to nothing. Real quick, it's just when you already have a lot of inflammatory triggers, even a little cholesterol will oxidize and create terrible problems. That's why you see cardiologists now trying to get your LDLs down below 70, even down to 50. So when you get it down that low, guys are going to have a testosterone issue more than likely. Females are going to have a hormonal issue as well. You have to be ready to say, if I'm going to drop cholesterol that low, how am I going to support hormones on the back end of that deal?
Very good. Well, thank you. So thank you, everyone who was able to join us today and stick with us. That does conclude our hormone boot camp for this session. And of course, there was a lot of information here, so we will investigate how we can further get some more education out to you, because this seems very well received and that people are really interested in it. Please remember that you have $100 off on a test. If you are interested in trying this new panel that Dr. Brock went step by step through. So utilize that promo code to order it on yourself or a couple patients. And thank you, Dr. Brock, for joining us today and all of the information and slides that you were able to get with us. We'll see you all again soon.
Bye-bye, everybody.
Bye.